One, it seems like we have quite the turnout tonight for this. I really appreciate everyone's time and giving me the opportunity to kind of go over a very popular subject in the field of urology. So just a quick introduction for myself. My name is Amar Raval. I'm a urologist, a part of AUI. I did my training at Thomas Jefferson University Hospital in Philadelphia and residency, and my medical school at Florida State. I am a general urologist, but I have special interests in kidney stones, BPH, overactive bladder, as well as robotic surgery. And I have two office locations that I primarily see patients out of. That's in Trinity, off of Ducks Loop Boulevard, and Racetrack Road in West Chase. And the topic of today's conversation is BPH. So what is BPH? BPH refers to an enlarged prostate. Typically, it's benign, obviously non-cancerous, and it's something that's very treatable and very, very common among men. In men between the age of 51 and 60, it's about 50% of the population, and in 90% of the population in men over 80. So who gets BPH? And there's multiple factors that include obviously age as a risk factor, hormone influence, increased testosterone, genetics. All of these can be factors to contribute to obstructive voiding symptoms. In this next diagram, you can see a normal prostate on the left with the bladder on top, and you can see urine flow through the urethra. Well, if the prostate gland enlarges, it can cause constriction and obstruction of flow. And for that reason, it can be a significant and detrimental problem for men and their quality of life. So what are the common symptoms associated with BPH? One is weak stream, sudden urgency, frequency, interrupted flow, hesitancy, straining to pee, feeling of incomplete bladder emptying, waking up many and many, many times at night. What are the complications associated with BPH? Well, these is where things get tricky and certainly involves consulting a urologist to see what options are available to help treat BPH. But urinary tract infections in men is a very abnormal problem and often means that there's a problem in the outlet itself. Bladder stones. Bladder stones can form if you have difficulty emptying your bladder and can collect with stasis of urine within the bladder due to obstruction from the prostate. When there's kidney failure or backup of urine flow into the kidneys, it can cause swelling, what's known as hydronephrosis of the kidney, and can ultimately affect kidney function. And therefore, it's really important that if you start developing obstructive symptoms, that you seek professional guidance. Incontinence can be a very embarrassing situation, urine leakage. And then ultimately, and we see this unfortunately, patients that come to our office with a catheter already in place because all of a sudden they shut down. It's very important to know that although prostate is affiliated with benign causes like BPH and has nothing to do with prostate cancer itself and does not increase your cancer risk. However, screening for prostate cancer is equally important. So how is BPH diagnosed? So if you were to come in my office and it's initial office visit, first time that you're seeing me, obviously a history and physical is very important. Learning if there's any genetics, if there's any family history, but of course, initial screening of also physical exam. And that starts with a digital rectal exam to determine the prostate size and if there's any irregularities on exam like prostate nodules. A common thing, what we call the stethoscope of a urologist, is a bladder scanner. So if you have problems peeing, obstructive voiding complaints, and some of the symptoms we discussed earlier, we can easily have you pee in the office and then use a nice scanner and place it over your bladder with an ultrasound machine and determine how much is left over in your bladder. There's a validated questionnaire that is often filled out in the new patient paperwork called an IPSS score. And this specifically clarifies voiding symptoms and an associated bother score. For me as the urologist, the most important question that I ask the patient is, how much does this problem or BPH bother you? How much does it affect your life? And if the bother score is high, then in my eyes, it's worth treatment. PSA blood testing is a routine blood test that should be done in men without any family history every year or every other year from the age of 55 to 70. Obviously, those cases can be done earlier or even after based on your medical history, family history. And a very easy test to do, again, is a urine test to see if you have an infection or if infections are a problem. And like I said earlier, if men are getting recurrent urinary tract infections, that's a big tip-off that there could be a problem with the flow and the outlet. How is BPH diagnosed? So we talked about initial office visit. The next step is really determining what the bladder function is like. We have easy tests and non-invasive procedures and testing called Urocuff and Uroflow, where you can pee into a funnel and it measures the rate at which you pee. And most men, this is very easy to do and not uncomfortable. It can take less than 5 minutes and really can determine bladder function and bladder emptying. In rare cases where men who are in retention with a catheter in place and they can't pee or have severe symptoms, urodynamics testing is used in certain situations. And that is what we call bladder function testing. This is a detailed assessment, a 45-minute test in the office where we can measure bladder pressure, bladder filling, the sphincter function, compliance, and it's very, very useful. In urology, I compared this to the echocardiogram, but really this is the echo of the bladder, where it can tell us a lot of information about the function and compliance of the bladder and prostate. Additionally, as a urologist, we are glorified plumbers. So if there's plumbing issues, we need to evaluate the plumbing. And to evaluate the plumbing, part of that evaluation involves cystoscopy. And that's using a camera to evaluate the lower urinary tract. As you can see in this picture, it's a flexible scope with a long rigid tube that goes gently through the urethra, entire up the tract, through the prostate, and we can tell the anatomic variation of the prostate. So you can identify how the prostate is blocking the urethra. Are there any urethral problems, strictures, or obstructions? Are there stones or tumors within the bladder? Is there a source of bleeding? Are there bladder irregularities like diverticuli? This is extremely important for a urologist to determine the size and configuration and really help us to determine what options are available from a procedure standpoint for the patient. The next functional test or advanced testing that we do is what we call as a transrectal ultrasound. This is an ultrasound that's placed in the rectum to determine the size and shape of the prostate. This is measured in cc's or grams. A normal prostate size is about 20-25 grams or cc's. Anything above that is generally an enlarged prostate. And this is extremely useful in determining what options are available for the patient. And then in this next section, we're going to talk about treatment for the prostate and what are the goals? What's the desired symptoms? And we'll go from the least invasive option to more invasive options. So lifestyle changes. Like I said, if someone's on testosterone replacement therapy, that can contribute, to prostate enlargement. Lifestyle and behavioral modifications like time voiding, not holding your bladder for an extensive period of times, that can be an issue. Certain medications can affect the bladder. So going over a review and prostate. So we go over a review of those medications to make sure that are not making the situation any worse. Talking about different medications for the prostate and procedures, some of which we'll review tonight, from Urolift all the way to robotic simple prostatectomy. So what are the lifestyle changes? This is a very easy thing. I kind of mentioned what we call bladder training and double voiding. So if you're going and you still feel like you're not emptying your bladder, we have you try again in 15, 20 minutes later. That way, if you have incomplete bladder emptying, you don't have stasis of urine, there's less risk of a urinary tract infection. Many men complain that they wake up multiple times a night to pee. Anything more than once is considered, pathologic as a problem. There are many reasons why waking up at night to pee, they're not just the prostate, but we go over that, whether it's obstructive sleep apnea, whether it's nocturnal polyuria, meaning you make more urine at night than you do during the day, whether you have diabetes that can be contributing, but certainly the prostate can be a big factor. So one of the lifestyle changes we recommend is emptying your bladder before your bedtime and not drinking any fluids 2 to 3 hours before bedtime. There are many dietary irritants that can affect the bladder and prostate: coffee, tea, citrus, alcohol, sodas, spicy foods. All of these can make lower urinary tract symptoms, or what we call irritative voiding complaints, worse. We should also avoid certain medications if you have severe symptoms. And obviously, I understand that there's medications that are very important for many medical problems. But just for instance, Benadryl or really any allergy medication, those can affect your bladder and prostate and put you in retention. Anti-anxiety or depression medications can also affect it, make it slower and harder to pee. Constipation is a huge factor that can irritate bladder function and the ability to empty and void. And the reason being is, based on the anatomy, the rectum is right behind the prostate. And so if that's full of stool, that can push on the prostate, push on the bladder, and make it difficult for you to empty. It's also very important to review over-the-counter medications. And quite frankly, there's a lot of over-the-counter prostate medications that are out there that are available, and not all of them can be necessarily helpful. So the first step, if you have these medications, I have a lot of patients that come in with severe symptoms and they've never been treated. Well, one of the things that many urologists start with and can start with patients interested in medication therapy is alpha blocker or 5-alpha reductase inhibitors. So what are these? The common trade name that we know is Flomax, or otherwise known as tamsulosin. These are medications that work at relaxing the prostate and relaxing the bladder neck to open up the prostate to allow you to empty better. It's a very common misconception that patients think that this may shrink the prostate. It doesn't. It actually just opens it up to allow you to empty bladder better at the bladder neck and sphincter level. There are several side effects associated with that, some of which can include retrograde ejaculation or dry ejaculate volume, as well as orthostatic hypotension. And what that means is lowering your blood pressure if you stand up real quickly. So postural hypotension. So if you have low blood pressure, these are medications we may want to avoid. Additionally, there's a medication that we usually add on top of this if you have severe symptoms, and that could be 5-alpha reductase inhibitors, medications we know as Proscar or Avodart or finasteride. These are medications that take at least 6 months to work, and that works at shrinking the prostate. Things to know, though, is that by shrinking the prostate doesn't mean that you'll actually improve the obstruction all the time, because even though you can make a big prostate from 80 grams, let's say, to 20 grams, that doesn't really always improve the outflow tract. It does have sexual side effects that patients should be aware of prior to starting the medication. So procedural options are really recommended if lifestyle changes aren't working, medications aren't working, or medications are a lot of side effects, or compliance is a problem, in which case testing that I alluded to and talked about earlier is the best next step. The beauty is with Medicare and Medicare Advantage plans and many commercial insurances, BPH procedures are covered. This is an embarrassing topic for many patients if they have severe symptoms, but it's something that I always advocate that it's important to get addressed from a professional and physician. So we're going to start with small procedures and minimally invasive procedures. And one of the common procedures that I perform now for many years is the Urolift system. This is a minimally invasive procedure that lifts the prostate obstructing tissue out of the way. So how does it work? And this is exactly what I tell my patients. It is exactly like curtains or implants that pull back the size of the prostate that you can see in this picture here. This can be done outpatient with either minor sedation in the office or in a surgery center, and can even be done under local anesthesia. Oftentimes, no catheter is required afterwards. I would say about 90% of my patients I do this on, I don't leave a catheter. This is a very easy procedure, minimally invasive, minimal side effects. That's extremely helpful and definitely prevalent in the field of urology today. So what are the risks and side effects of this procedure? Well, they're minimal. You can have, in the short term, irritative voiding symptoms like urgency, frequency, some blood in the urine. This can last anywhere from 1 to 4 weeks. You can have burning with urination. The beauty of this particular procedure is that there's zero erectile or ejaculatory dysfunction. This is a very popular procedure that patients request, and it's something that can be done in a large population of my patients. It requires limited recovery, limited restrictions, and no tissue is removed. Another in-office procedure is the Rezūm system. This is an in-office, minimally invasive procedure that uses water vapor therapy to shrink the prostate and reduce obstruction. So how does it work? You can see the device on the left. It uses sterile water vapor that's released through the targeted prostate tissue. So steamed tissue, water comes in contact with the prostate tissue, releases energy, and over time, the body absorbs the treated tissue and reduces the prostate size. So what are the side effects of this particular procedure? They're very similar to the Urolift as far as urgency, frequency. In some cases, you can have a little bit more irritation as far as burning with urination, passage of debris, blood. There's a small risk of decreased ejaculatory volume or painful ejaculation, urinary tract infection, inflammation of the prostate or epididymis. There's also a very rare risk of developing a urethral stricture or scar tissue in the urethra, for having delayed, urinary retention, and a low risk of erection or ejaculatory dysfunction. Typically, a catheter may be needed for a couple of days postoperatively, and this is different than the Urolift procedure in the sense that with time you can have involution of the prostate and some removal of tissue, so to speak. The gold standard that everything is compared to, including the minimally invasive procedures, is what we call the TURP, and that stands for transurethral resection of the prostate. Many of my patients refer this as the Roto-Rooter procedure. I think that's a little bit on the harsh side, but it's certainly, the concept is there. And how that works, and this is something that's done under general anesthesia. We have a specific device, what we call a bipolar loop, that used to core out the prostate to remove tissue that is blocking the urethra. This is extremely effective. It's been proven for many years, and truly is the gold standard treatment option. And as you can see in the picture on the right, there's a rigid resectoscope or sheath that's going all the way to the level of the bladder, has a loop at the end, and you use that to remove and core out the obstructed part of the prostate. So as I said, it requires general anesthesia. A catheter is generally left overnight. In most of my patients, I take it out the next day, and some with very large prostates, we leave it in for a few days and remove it in the office. What are the risks and side effects? Ejaculatory dysfunction being one, low risk of erectile dysfunction, hematuria or blood in the urine, and burning with urination that can last several weeks. The beauty of this procedure is that it's resective. And when you resect tissue, you may have a way dramatic result in the flow after surgery. Another surgical option that has certainly caught the urology field a little bit by storm is aquablation. And aquablation therapy is a play on the transurethral resection of the prostate, and it uses powerful heat-free water jets to remove excess prostate tissue. So it is resective. It uses surgeon-assisted robotic technology and real-time image-guided vaporization of the prostate tissue. This does require general anesthesia, and this does require an overnight hospital stay. The beauty of this procedure is that you do have a transrectal ultrasound during the operative procedure, and you can see the bladder neck, you can see the sphincter, and it helps minimize and visualize any other intraoperative complications that can happen and can have lasting effects on the patient if done incorrectly. So what are the risks of aquablation? This is very similar to TURP, except for two pieces that I'd like to stress. So it does cause burning with urination. You can have blood in the urine. It does have a very low impact on erectile function. But the beauty is 9 in 10 men can preserve ejaculatory function. 99% do not experience incontinence. And the reason being for these two is under live, visually guided robotic surgery, you can avoid the sphincter and areas that could affect the ejaculatory ducts and affect continence. Typically, the catheter is left for a few days. Treatment is definitely prostate size dependent, and the extent of ablation is using real-time ultrasound. Another excellent procedure that I also perform in some select cases is robotic simple prostatectomy. Now, this is robotic surgery that's done laparoscopic with the Da Vinci robot with incisions on the abdomen, and this can be done to remove the inside of the prostate. So this can be done, which we call extravesical or intravesical, where you can open up the bladder and core out the prostate tissue using robotic surgical techniques. And the beauty of this is it can minimize incisions. You can have a speedy recovery. It does require a hospital stay overnight. It does require general stay anesthesia, and it definitely requires a catheter for a few days, especially if you're opening up the bladder to core out the prostate. The amount of tissue that can be removed can be quite significant using this technique, and is certainly very, very beneficial with men with very large prostates and enlarged median lobe. So what are the side effects associated with this particular surgery? Ejaculatory dysfunction, urinary incontinence can be seen in up to 5% of men. And the reason that is because this case is generally used in men with very, very large prostates. Blood in the urine, burning with urination, urgency, frequency. You can have bladder damage, again, because you're opening up the bladder to remove the prostate. You can have urethral damage or scarring of tissue because you're using cautery. And there's a low risk of erectile dysfunction. There's definitely a longer recovery period compared to endoscopic procedures because you have incisions on the abdomen. It's an abdominal procedure. And then prostate tissue, just like the TURP, and you are sent out and you can check for cancer. So I know this was a thorough and kind of quick review, but hopefully this provided more insight for the topic of BPH. And it's very important that if you do have these symptoms and you are concerned, that you see your urologist, or of course, you can always see me as well. And my offices are listed below at Trinity and Duxley with the phone number, and my Tampa office in Westchase. Thank you, guys. And now I'm just going to answer some questions that are coming through. So the first question is, what percentage of Urolift patients see positive results, and what percent see no improvement? So it's a very good question. And a high percentage of my patients do see positive results. To give you percentages, I would say that this is something that needs to be done on the right patient. So the patients that have, anywhere from 20 to 100 gram prostates that do have obstructive voiding complaints, they can have a large median lobe, but in the right patient with no elevated bladder neck, no urethral stricture, patients can do exceptionally well. The next question, am I familiar with iTind and Optilume catheter approaches? This is another excellent question. I'm very familiar with both. Optilume is another balloon dilation technique for the prostate that I've used already in the urethral stricture space, and is starting to gain favor, and I have as an upcoming option and minimally invasive option. The benefit of this is it's not resective. It does, sort of compete with the Urolift system, and there's no, clips or anchors being used during the procedure. Another question is, does Urolift procedure help with frequency of urination? It certainly does. Urolift can be extremely helpful with frequency of urination. However, this is extremely important to delineate whether this is bladder or prostate related. And the way to elicit that is from, urodynamic studies and just, simply a clinical history. And obviously looking at the outlet to see if there's obstruction contributing to the frequency. A question I was asked, how many aquablations have I done, and what's your experience on small prostates, and how many patients end up with erectile or ejaculatory issues? I've done over 100 aquablations myself. I have great experience with small prostates, but particularly great experience also on very, very large prostates. I don't think I have a patient that I'm aware of with any issues with erectile dysfunction from that. And I would say my data personally is very much in line with the data out there for aquablation, which is about 7 to 10% risk of ejaculatory dysfunction. But someone who really cares about that, I'm extra careful as far as sparing the sphincter. I'm getting a slew of questions, so I'm doing my best to answer these as quickly or as efficiently as possible. The next question is, I had the Rezūm procedure done several years ago. How long should symptoms relief last? Well, look, there are failures with minimally invasive procedures. Obviously, if you're having recurrent obstructive voiding symptoms, the next step is to tell the urologist. You would do a cystoscopy to see if there's still any obstruction left, but typically a Rezūm procedure can last 5 years. And another question here is, I'm getting a lot of questions about prostate artery embolization. Prostate artery embolization is definitely becoming a very, very common and marketed procedure. There are certain instances where I feel like prostate artery embolization is very effective. One is if you have recurrent hematuria or blood in the urine that's prompting you to develop blood clots and require surgery. In that instance, prostate artery embolization to stop that is very, very helpful. The downside, it can be a painful procedure. Additionally, PAE is also very helpful in the patients with extremely large prostates that you want to shrink. But again, as far as symptomatic relief, it can be extremely helpful, but it doesn't, in all instances, doesn't necessarily improve the outlet itself. Often I have many patients that have had PAE and then have come to see me because they still have persistent symptoms. Their prostate size has reduced dramatically, but they're still obstructed and require further intervention. The next question I have is, how long does aquablation last? Aquablation should last about 10 years. And the reason I say that is a good resective procedure, whether it's a simple prostectomy, aquablation, and the gold standard TURP, I often tell patients it should last you 10 years plus or minus. Another question I have, sorry, I'm just trying to read these. Does scar tissue form or grow over the Urolift system to the point of re-blocking the urine flow? Absolutely. There's no doubt that over time, a prostate can regrow. And there's many instances where after 5 years, and data now is supporting that Urolift system can go beyond that, where you have obstruction. The beauty is all of these options are still an option down the road. You can have Urolift done again. Obviously, Optilume, Rezūm, TURP, Aquablation, these are all something that can be done. But anytime, like I said, as a plumber, if there's problems in the plumbing by any of the procedures, it requires a reevaluation to see what can be done. After the Urolift procedure, how long before one can continue normal activities? I tell my patients in about 24 to 48 hours, they can really do whatever they want to do. I mean, I wouldn't have them go deadlifting or squatting or doing anything extremely excessive, but they can, go play golf, go run, go do these. I don't have any restrictions as far as that concerned. Another question is, how recent should the urodynamics and ultrasound diagnosis be performed? For me, a transrectal ultrasound over a couple years is, plenty. It's not something that needs to be done yearly or anything beyond that. But for me, it gives you a live look as to what is the prostate size is now. Urodynamics, I really reserve for, because it is invasive, for select patients that have a lot of bladder and obstructive voiding complaints, or in patients that have a catheter in and you're unclear if the bladder actually squeezes well enough that if you were to do an outlet procedure, would the patient be able to pee on their own? Another question, does the medication dutasteride shrink the prostate? What are the advantages of it compared to tamsulosin? So as I mentioned in this slide, dutasteride is a 5-alpha reductase inhibitor. It shrinks the prostate, takes about at least 6 to 9 months to work, and can be helpful. Specifically, can be helpful in men who have recurrent bleeding from enlarged prostate, men who have a history of urinary retention, and again, can shrink the size of the prostate. Those are the advantages. Tamsulosin doesn't shrink the prostate. It's a medication that relaxes the prostate, that improves urine flow. Does solifenacin help with nighttime frequency? So the answer to that is it can. Solifenacin is an overactive bladder medication or an anticholinergic that can calm the bladder down. But like I said earlier in my presentation, nighttime frequency, known as nocturia, can be really a problem of many different issues or multifactorial. Things like diabetes, producing more urine at night, obstructive sleep apnea, BPH, just simply drinking a lot more fluid at night. So there's a lot of things that can be done in the clinical history that can discern whether what can be done to help, peeing less at night. I had a Rezūm procedure done several years ago. How long should relief last? So again, in the minimally invasive procedures, I always counsel my patients that Rezūm or Urolift should last you at least 5 years. After that, and again, plus or minus. So if it lasts longer, great. If it doesn't, well, it's an easy procedure enough that can be done again. And again, you can use a cystoscopy to check the outlet if they're having persistent problems. Another question is there a way to test the elasticity of the bladder? Absolutely. And the answer for that is urodynamics. That is bladder function testing, which is a 45-minute test in the office. What is the success rate for aquablation? That's another question. Aquablation is extremely successful with men that have obstruction because it is a resective procedure, just like the TURP, just like a simple prostatectomy, that should very well improve the flow, undoubtedly improve the flow in a man who's obstructed. Do I perform iTind or Optilume procedure? I do not perform iTind personally. I do perform the Optilume procedure. It says, what is your opinion on cryotherapy of the prostate? Cryotherapy of the prostate is a topic all on its own and specifically used in patients who are dealing with prostate cancer. So I'm going to leave that one aside. How can you tell if aquablation failed? Well, that's pretty easy. You can tell if aquablation failed by simply talking to the patient, seeing if they have persistent obstructive voiding complaints. And if they do, then the next step is to look inside with the scope. And if it's obstructed, then they may need another procedure done. Someone asks, and this is a good question, I pee once every night, sometimes twice. Is this serious? The answer is enlarged prostate or BPH is typically not serious unless you have recurrent urinary tract infections, you're bleeding all the time, you're developing bladder stones, you're having kidney damage, or you can't pee at all. So if you're waking up a couple times at night to pee and it doesn't bother you, doesn't affect your quality of life, then it's not serious at all. And myself included, I wake up a couple times a night, but that's simply because I drink a lot of fluid before I go to bed and nothing during the day. So by me reducing my fluid intake before bed, I end up don't waking up at night. So there's a lot of different options that are available, lifestyle modifications that can easily be done to help people. Okay, I'm going to answer 2 more questions and then I'm going to conclude for the night. Okay, the next question says, one of the questions, if the alfuzosin or tamsulosin works, would any procedure be required or would the medication be sufficient? This is a fantastic question. The answer is no, nothing is required. But if you want to get off the medication or the medication is causing side effects or the medication that you don't want to take long term because it's cost prohibitive or it's just something you don't want to be on long term, then it's a discussion with the urologist. Then you say, hey, I want to be off this medication. What's my next step? And that's where, measuring prostate, looking inside with a scope to determine what procedure is the best one for you. Okay. And I get this often. Quick connection issue, but the question was, if I understand the prostate encircles the urethra, how are you able to core out the prostate? You must have to penetrate the urethra, right? So this is a great question, and I get it often in the office. The truth is all of this tissue is connected. They're not necessarily separate entities like you see in diagrams. So yes, you do go through the urethra, but the prostate tissue can push into the urethra. And that portion of the urethra is called the prostatic urethra. So it is in that area, you can core out that tissue and really cause no problems to the urethra, so to speak. However, with any resective procedure like TURP, like Aquablation, tissue can be a complication or side effect. Another question, and I'll wrap it up with this one. How is it determined which is the best procedure for each patient? This is a fantastic question. And my goal of my presentation would be to answer this one, which is, first and foremost, it's a discussion with the patient. What are the expectations? What are they looking for? So if ejaculatory dysfunction, sexual side effects is paramount, then minimally invasive procedures with low risk of ejaculatory dysfunction, erectile dysfunction, Urolift, Rezūm, like Aquablation, these are something to consider. If you're in retention and you can't pee on your own, then listen, something where you're trying to remove as much prostate tissue as possible, things like Aquablation, Robotic and prostectomy, TURP, these are all excellent procedures. So there's a certain profile, there's benefits and disadvantages associated with each. All the procedures are useful, and they're all can be used in different clinical situations. I think it's very important for the urologist to be able to discuss that with the patient and lay out a game plan as to and tailor the treatment to the patient and their expectations and needs. Thank you, buddy, for your time. I hope this was a beneficial webinar, and I'm looking forward to participate again. As you can see on the slide, you have my office number. You know my name, Amar Raval. You may be a patient of mine or not, and either way, if there's anything I can do to help you, please don't hesitate to reach out. Have a wonderful night, and looking forward to doing this again. Take care.